Hi, my name is Judith Hahn, and I'm going to present to you my talk today entitled Phosphatidylethanol Biomarker Sensitivity Among Adults Reporting Unhealthy Alcohol Use, an Individual Patient Data Meta-Analysis. I want to thank my co-authors on this study. Before I tell you about our meta-analysis, I want to tell you why I became interested in alcohol biomarkers and how this meta-analysis arose. HIV and risky alcohol use are overlapping epidemics in sub-Saharan Africa, as you can see by these maps, and thus I aim to work on mitigating the harm of alcohol use in this area. However, in beginning to explore this topic in persons starting HIV medications, we found very low levels of self-reported alcohol use and suspected underreporting of drinking. This may be due to very high levels of social desirability, as well as the fact that some alcohol drinks are hard to report. This picture shows a local drink called Malwa that's consumed communally with long straws. With the help of Marty Javers, we confirmed that these suspicions by testing for percent CDT in stored samples. With the collaboration of Wolfgang Weinmann and Frieder Wurst in the late 2000s, I conducted a PEth validation study among persons with HIV in Uganda, using breathalyzer testing as a gold standard, as shown here. We found that PEth was highly sensitive and specific for any and for heavy alcohol consumption. Since then, there has been a growth in the use of PEth as an objective measure for alcohol use in HIV research, as depicted here by increasing PubMed citations. Due to the harms of alcohol use on HIV, the field is focused on unhealthy drinking, as defined here. While I noted that several studies began using PEth, 2 studies found surprisingly low proportions with PEth-positive tests among women with HIV reporting fairly high levels of alcohol use. This gave impetus to our examining of whether PEth sensitivity for detecting unhealthy drinking differs by certain characteristics, including by gender, age, race, ethnicity, by method of DBS preparation, and by biological characteristics such as body fat, anemia, HIV infection, and liver disease. These questions have been previously examined in several individual studies, but never all together. So we undertook an individual participant data meta-analysis for PEth sensitivity to examine these questions. An Ipd Meta-Analysis combines raw data across several individual studies. It is similar to a classic meta-analysis, except that the raw data allows for analyses not conducted in published studies. To conduct this, we searched the PubMed database and additionally sent emails to known investigators. Studies were eligible for the Ipd if the study designs were such that they could not be prone to overreport of alcohol use. The studies also needed to have measured PEth with a limit of quantification of 8 nanograms per microliter and conducted AUDIT-C or the timeline followback. We included studies that were conducted or published between January 2000 and December 2019, and the studies had to have at least 30 unhealthy drinkers. We found 269 studies via PubMed and 23 via other sources, and ended up with 21 studies in the analysis. We limited the observations to those with AUDIT-C positive scores indicating unhealthy drinking. We conducted mixed effects modeling using random effects for study site, robust standard errors, and a logit link. We used multiple imputation for missing data. The outcome variable was being PEth positive with a cutoff of 8 nanograms per microliters. The predictors were age, sex, race, ethnicity, method of specimen collection, and the biologic variables of body mass index, hemoglobin, HIV status, and fibrosis. We controlled all our models for AUDIT-C score. The 21 studies included over 3,000 people and over 4,000 observations, spanning 4 continents. 31% were female, and we had a fairly even distribution of Africans, African Americans, and whites. The median AUDIT-C score was 6. The median PEth value was 70 nanograms per microliter, and the proportion with PEth-positive tests was 79.3%. I note that the PEth testing was done at the U.S. drug testing laboratories for 20 of the 21 studies. So here's our basic model that included all 21 studies. We found, as expected, that AUDIT-C score was associated with higher odds of PEth sensitivity. We found no association of sex, race, ethnicity, age, and method of blood collection with PEth sensitivity. Our next model added in the biological variables and was limited to the 13 studies that had these variables measured. Again, the AUDIT-C was associated with PEth sensitivity, while sex and age were not, although Africans and African Americans versus whites had higher odds of PEth sensitivity. In addition, higher body mass index was associated with lower odds of PEth sensitivity, higher hemoglobin was associated with higher odds of PEth sensitivity, and being infected with HIV was associated with lower odds of PEth sensitivity. Our final model was limited to the 9 studies that also had data available for the fibrosis score. The results were very similar to the prior model, but in addition, the fibrosis score was associated with PEth sensitivity. We conducted several pre-planned sensitivity analyses and found no major differences in the results. The limitations of this study is that not all the studies had biologic measurements, that race ethnicity groups are social and not a biological construct, that body mass index is a crude measure of body fat composition, and that even though we tried to minimize underreporting, we did need to rely on self-reported alcohol use to control for level of alcohol use. The strengths of the study are that this was the largest ever sample size for examining PEth sensitivity. This was also the first analysis of all these factors together across a wide array of population characteristics. We conclude that PEth was sensitive for detecting unhealthy alcohol use, but this sensitivity may be impacted by body mass index and hemoglobin, and we also found that HIV infection, liver fibrosis, and race ethnicity may play a role. Clinicians should be aware of this when receiving negative PEth results. Thank you. I'd like to thank my co-investigators who contributed data and interpretation, the study participants, and the funders. And please do contact me for more information, and I always welcome new collaborations. Thank you.